2 weeks later, I got a telephone call from Dr. Huggins to tell me that yes, indeed, I did have alpha-1 antitrypsin deficiency. Now, let's take a break from my personal story for just a minute and talk about alpha-1. What is alpha-1? Number one, this is something I learned from Dr. Mark Brantley down at the University of Florida. He starts his alpha-1 presentations with this slide when he's talking to medical professionals. And it is the fact that alpha-1 is a laboratory diagnosis. It's not a clinical diagnosis. So any of you in here who are having breathing problems, who have been told by your doctor that you do not have alpha-1, but they've never tested you for it, they are lying to you. They may not mean to be, but they are not telling you the truth because they don't know. If you have breathing problems, you should ask your doctor to test you for alpha-1, period. Chances are you don't have it. You probably don't. It's only about 1 to 3% of anyone with COPD that actually has underlying alpha-1. But you need to be screened to make sure, because if you don't find out, you won't get treated. And if you don't get treated, you're going to continue to decline for no reason. Right, so what is alpha-1? Basically, it's an imbalance in the proteins and enzymes in an individual's lungs. It's an inherited protein deficiency. You're born with it. It's not something you develop. It just develops over time. It's a disorder that leads to disease. And the basis of it is that in a normal person with the normal alpha-1 levels, the level of destructive enzyme in their lungs that should be there, it should be there to destroy dead tissue and bacteria and things like that. It's a very low level normally. And the level of alpha-1 protein is very high. So it balances out with the neutral elastase, the dangerous enzyme. And so the dangerous enzyme can't become dangerous. It keeps it under control. Someone with alpha-1 deficiency, number one, has a higher level of this neutrophil elastase, this damaging enzyme. They have a higher level because it's a nature of the disorder. That level starts increasing over time as they age, getting older and older. And in combination with that, they are born with this low level of alpha-1 in their bloodstream and in their lungs. So there's not enough to balance out the high levels of this destructive enzyme. And so what ends up happening is this enzyme starts eating away at healthy lung tissue. And it literally can happen at any time. It could happen in someone's, in their 20s, it could happen in their 70s. There is no rhyme or reason. Generally, it will happen earlier if you smoke, later if you don't. And there are some individuals who will never be affected by it, but there's some who are affected drastically at a very early age, kind of like me. So that's enough of the science of what alpha-1 is. More to the point, the way it's inherited is that you've got to get it from both of your parents. You've got to collect a Z gene, a very deficient, alpha-1 deficient Z gene from each of your parents. And if you get both of those, if you just happen to have two parents who carry one of those genes or more, and you inherit both of those, then it can lead to a severe deficiency that can then lead to lung and liver disease. So it sounds like the chances are nobody's going to ever get this, right? Right? But the fact is that 25 million Americans carry at least one deficient genes, one of these genes. So how difficult do you think it would take for two of these 25 million Americans to get together and have kids? Like my parents, for example. Having 25 million Americans carrying at least one of these genes leads to alpha-1 affecting an estimated 100,000 people in the United States. That's a big, big number. And I'm going to tell you something a little bit later that'll make that 100,000 look even bigger. Number one, it makes it one of the most prevalent, potentially fatal, inherited disorders ever. It's right up in that level with cystic fibrosis, and everybody knows what cystic fibrosis is. It just hasn't been, people haven't been aware of it as much. The awareness level is not as high as it is for alpha-1. And number two, it is the most common known genetic risk factor for COPD. So this 1 to 3% is a known factor, a contributor to COPD. Now, This is the unfortunate part, is that 95% of the alpha-1 patients in the U.S. have gone undiagnosed, remain undiagnosed. There's a big push with a number of different organizations, drug manufacturers, not-for-profit organizations, the American Lung Association. More and more and more, there's a push for more and better awareness and detection. But unfortunately, it's working very, very slowly, and we want to speed it up a little bit. And one of the ways to speed that up is getting an educated consumer, an educated lung disease population, so people understand what it is that they're talking about and what it is that they're dealing with. So the next question is, how do we start working on this? For the respiratory therapists in the room, you need to understand this simple word. It's a little anagram I made up called CARB, like a carbohydrate, a carb. Any individual who's been diagnosed with COPD, any individual who has persistent asthma after aggressive bronchodilator treatment, like me, relatives of anyone who's been diagnosed with alpha-1, and bronchiectasis. So if you see those patients, you should, or if you're a patient who has one of these issues, you should be screened for alpha-1. Please also, you can keep your eyes open for any individual with shortness of breath, wheezing, chronic cough, and recurring chest colds. Again, perfect description of what was going on with me, but it didn't click in anybody's mind. So, how do we treat for alpha-1? There's 3 basic tests, and you don't really need to worry about this that much. There's the serum level, which is how much alpha-1 is in your bloodstream, a phenotype, which really tells a little more detail, but it's a manual test and has some inaccuracies, and it's very expensive and time-consuming. And probably the best test that's out there right now is a genotype. It's a itty-bitty little tiny sample, and it's highly accurate, and it'll tell a simple yes or no, are you carrying one of these genes or not? And then follow-up testing can be done right after that. But it's easy and in many cases free of charge. So how do we treat it? Again, it's a deficiency of a protein, so logic says let's put the protein back in the body. There are 3 manufacturers out there right now, and two are in the room. But these are all good drugs. They all work, and like I said, there is product out there. It's available. Treatment is not an issue. So in summary, alpha-1 is a laboratory diagnosis. It's not a clinical diagnosis. About 25 million Americans carry at least a gene. 100,000 have it, and an incredible amount of misdiagnosis and underdiagnosis. Patients should all be screened for CARB. Anybody remember what these stand for? What's a C stand for? COPD. The A, asthma. The R, relatives. And the B, bronchiectasis. Yeah, not easy to say, is it? And that screening is easy, free of charge in most cases, and augmentation slows lung decline.